Thank you, ma'am, for that moving and clinically grounded presentation. We now open the floor for discussion for 5 minutes. Since we are running late, we invite your thoughts and questions.
Good afternoon. So that was very extensive and informative lectures on 3 different topics. So anesthesiology is one specialty where they definitely need to know about everything, all the drugs and techniques they use. And Dr. Shashidhar told about that they need to know about all the neoadjuvant drugs, all the chemotherapy drugs, immunotherapy, and about the effects of radiation on the patient, so that the evaluation depends on whatever the chemotherapy drugs they use. That's very important. And Madam Manjula told about how to manage a hyperactive surgeon also along with managing the child. So because anesthesia is not only about the patient, sometimes they need to manage the surgeon also. And Dr. Malavika told about not only we are anesthetizing a living person, even how to manage a person who is brain dead for organ retrieval. So now the topics are open for discussion. Any questions from the audience?
Shashidhar sir. So what about the timing of surgery? Will it depend on the type of neoadjuvant therapy, or is it same for all the patients? Will you allow the time for recovery of the immune system?
Yeah, definitely. We need to give time to recover, because post-chemotherapy, usually they are given in cycles. So usually it's a 21-day cycle or weekly cycle, depending on what condition they are. So usually we give 2 weeks of time period should be good enough to recover the patient from the toxicity, whatever they have been undergone. So 2 weeks time period should be given for prehabilitation, not for the recovery. It's the prehabilitation that is most important, because that 2 weeks will give us nutrition build-up, your breathing exercises, if at all what surgery you are going, education and counseling, and also correction of anemia. All these things require at least minimum of 2 weeks for the time period.
Thank you, sir. Manjula, madam. Yes, sir. For any history of a URTI patient, if the patient is undergoing any lower abdominal surgeries, which is better, ma'am, a spontaneous ventilation with holding mask, or securing airway with the LMA or endotracheal tube with caudal? In some centers, they practice with mask holding.
It is depends on which part of the surgery, and also age of the patient most of the time. And now you are practicing spinal also in so many centers, as we know. So you always take a surgery consideration, part of the surgery, and timing and patient's condition, and depend upon that, and always risk factors. Whether even with the spinal, whether you can manage that. Sometimes even with your oxygen supply or anything, patient can have spasm anytime. It is not the question of only that. Only it is always better if it is not airway considered, you can still go for a surgery if it is an emergency. But if airway is involved, then you have to always think about the risk. And if postponement of surgery can benefit the patient, you postpone. Otherwise, surgery is mandatory. It depends upon the patient. Your surgery is mandatory, it definitely improve the patient condition, then you have to take a risk. So it is always individualization of patient condition and how you will manage, and your expertise in that, and whether you have all the gadget or environment to monitor that or manage that case. So pediatric, you always need one extra help most of the time, as all anesthesiologists agree for it.
Thank you.
So alone, with all risk factor, it is very difficult to manage. I think some other seniors can contribute.
One question to Malavika madam. Madam, you mentioned about coronary angiogram for a brain dead patient to manage a brain. How does it help?
It's basically for the extended donor pool. Now they say that just to increase the rates of deceased organ donation and to rule out any subclinical coronary stenosis, it is indicated. But it depends on the patient. It's not conventionally and routinely performed. So generally what is performed is the transthoracic echo, And along with that, our invasive lines are there, which usually give a lot of mine of information, along with the other tests like ABG, which are repeated. This is generally done, but it can even extend to that. That's what the literature says.
Madam, nowadays they are doing a post-circulatory failure, this one, organ retrieval. Is it better than brain dead patients or what?
No, it is inferior to the donations that occur because of from the brain dead patients. Because here the warm ischemia time is prolonged, there is a high chance of graft rejection. It's mainly done for the liver and the kidneys. Still, even following the transplantation, the results do not tend to be that good. However, this is giving a last chance to the patient who is in organ failure. So that way, donation of from circulatory death is done, but it's not widely practiced.
When is the hormonal replacement started for the brain dead patient?
So,
And when is the hormonal replacement started, and what are the hormones to be replaced?
generally, it is started when the patient is unresponsive to the vasopressors as well. And vasopressin is given with the intention of handling central diabetes insipidus also, as well as patients who are hemodynamically unstable. So that is the first drug which is to be started. Subsequently, if the patient doesn't respond to vasopressin, then norepinephrine can be added. And further, if the hemodynamic instability persists despite that, then the thyroid hormones are given. But generally in our institute, what is followed is the vasopressors and the steroids are given. We give hydrocortisone, 300 milligrams initially, followed by 100 milligram 8th hourly. And insulin therapy is given for the control of blood sugars. The thyroid hormones, the role is generally controversial, but it can be given, yes.